Before we hit the disease by itself, first we'll talk about the basics. So as we all know that adrenal gland has two parts, one is the cortex and the medulla. Cortex is divided into three zones. Zona glomerulosa, which secretes mineralocorticoids, zona fasciculata, which produces glucocorticoids, and zona reticularis, which produces the gonadal steroids. So the mineralocorticoids, they mainly responsible for regulation of blood pressure and electrolyte balance. The glucocorticoids mainly for blood sugar, blood immune system and metabolism, and steroids, of course, the androgens, they have different roles in different sexes. If you have to look at the physiology, it's mainly the stressors like hypoglycemia, hypotension, trauma, surgery, fever. They act mainly at the hypothalamus to produce CRH. CRH will act on the pituitary to produce ACTH. ACTH will cause the release of glucocorticoids, which causes changes in the metabolism and cardiovascular system. Whereas it's the renin-angiotensin system which plays a very important role in the activation of aldosterone, and it's mainly by the secretion of renin from the kidney, and renin acts on angiotensin from the liver, which converts into angiotensin 1, then angiotensin 2, which acts on the aldosterone. Aldosterone will act on the extracellular volume, causing potassium excretion and sodium retention as well. So Addison's, the adrenal insufficiency, what is the etiology? Why does it actually happen? So as I said, primary adrenal insufficiency or Addison's disease, it's a little different from the secondary causes. So primary Addison's disease is usually because of autoimmune causes. Autoimmune, it can be sporadic or it can occur along with autoimmune polyendocrine syndrome type 1, where there is mucocutaneous candidiasis and hypoparathyroidism as the main accompaniments, or type 2, where it's occurring with hypothyroidism, hypogonadism and insulin dependent diabetes mellitus. In India, the commonest cause for Addison's disease is in fact infections. Tuberculosis is the number one cause. Cytomegalovirus, HIV, fungal infections also can cause it. Metastatic tumor to the adrenals, we have seen 3 cases in my lifetime, I have seen at least. And lymphoma of the adrenals is also a very important cause. Infiltrations like amyloidosis, hemochromatosis, and something that we have read from our MBBS days, intra-adrenal hemorrhage due to meningococcal septicemia known as Waterhouse-Friderichsen syndromes. There are some monogenetic causes also for Addison's disease. We cannot remember the names of all of them, but they are mainly divided into congenital adrenal hypoplasia syndromes or congenital adrenal hyperplasia syndrome, of which 21 alpha hydroxylase deficiency is the commonest. Autoimmune involvement, as I said, it can occur isolated or part of APS, and antibodies are mainly directed towards 21 hydroxylase, 17 hydroxylase or CYP11A1 desmolase. So in autoimmune adrenalitis, what happens is, first the adrenals will enlarge in size and then finally they will atrophy because of fibrosis, and glomerulosa is first affected, followed by reticularis, followed by fasciculata. Autoimmune adrenalitis might be associated with other illnesses in the body, mainly autoimmune conditions, thyroid being the commonest accompaniment, where hypothyroidism or toxic non-toxic goiter can occur. People can also have premature ovarian failure, very common association with Addison's disease. Type 1 diabetes, hypoparathyroidism, pernicious anemia can also occur with autoimmune adrenal insufficiency. What are the causes of secondary adrenal insufficiency? Number 1 cause is the exogenous glucocorticoid therapy. So you are giving exogenous glucocorticoids from outside and suddenly withdrawing, CRH, ACTH, everything will be suppressed. Hypopituitarism, selective removal of ACTH secreting tumors in Cushing's. There are pituitary tumors, craniopharyngioma, either because of pressure effect or because of surgery, because you do for them, or if you give radiation to the pituitary for them also, they can all cause secondary adrenal insufficiency. Pituitary apoplexy can also cause this, and in our country, in many countries, Sheehan syndrome is one of the common causes for developing pituitary hormone ACTH deficiency. The isolated ACTH deficiency can occur because of lymphocytic hypophysitis, many monogenetic disorders, and multiple pituitary hormone deficiency can also occur due to monogenetic disorders. Roughly, if you have to distinguish between primary and secondary adrenal insufficiency, it is the ACTH value. So ACTH will be high in primary adrenal insufficiency, and in secondary adrenal insufficiency it will be low.
aldosterone-renin axis is preserved in secondary adrenal insufficiency, whereas in primary adrenal insufficiency, aldosterone and renin axis gets totally disturbed. Then another way to distinguish clinically is the skin pigmentation. So ACTH, they act on the melanocyte stimulating hormone receptors and they cause darkening of the skin, especially in the mucosa, buccal mucosa, and if there are any scars in the body, they become dark. So this is primary adrenal insufficiency will have pigmentation, secondary adrenal insufficiency will not have this sort of pigmentation. Clinical features, it can present insidiously or it can present as an acute crisis. Insidious onset symptoms are mainly weakness, tiredness, fatigue, anorexia. Many patients will come with GI symptoms, nausea, vomiting, abdominal pain, diarrhea, and salt craving might be there in a few percentage of patients. Postural dizziness might also be there. Hypotension and weight loss are the pathognomic clinical features of Addison's disease. Person is losing weight continuously and having hypotension. In the presence of hyperpigmentation and vitiligo, these are all very important signs of Addison's disease. And lab findings, we'll discuss again in detail, but hyponatremia followed by hyperkalemia are the commonest findings. It can present suddenly as an adrenal crisis also. So it's a hemodynamic abnormality with absolute or relative hypovolemia which gets corrected by parenteral corticoids, and this usually occurs because of infection, stress, or a person is undergoing surgery. The commonest cause is in fact default of medication. So a person who has been diagnosed with Addison's disease being treated with cortisol or hydrocortisone suddenly stops it, then they'll go into an adrenal crisis. And how do you identify an adrenal crisis? The patient will have dehydration, hypotension and shock that is out of proportion to the severity of the current illness. Another common problem is they'll have a lot of GI discomfort, nausea, vomiting. Already the patient is having weight loss and anorexia. This will worsen the condition. Acute abdomen is very common. Unexplained hypoglycemia, unexplained fever can also cause. Of course, again, as I said, the pigmentation in the mucosa and over the scars are very, very important for the diagnosis. And electrolyte imbalances in the form of hyponatremia, hyperkalemia, azotemia, eosinophilia are also very common in this particular condition. How do we investigate these patients? So biochemistry will give us a clue. Hyperkalemia. Hyperkalemia will occur in primary adrenal insufficiency because of the alteration in the renin-aldosterone axis. There is actually retention of potassium in this particular condition, and it is absent in secondary adrenal insufficiency. Hyponatremia can occur in both, but hyponatremia is usually because of salt loss in primary adrenal insufficiency. But in most pituitary conditions, there will be increase in the vasopressin, which causes dilutional hyponatremia in both secondary adrenal insufficiency. Hypercalcemia is a common accompaniment. Raised liver transaminases can also be seen. There will be a little bit imbalance in the TSH free T3, T4, but if there is a persistently elevated TSH and positive thyroid antibodies, suspect along with Addison's disease, the thyroid, autoimmune thyroid illness as well. How do we test then for cortisol? For cortisol, we usually do a 8 AM cortisol. 8 AM cortisol, if it is more than 14.5 micrograms per deciliter, we have almost ruled out Addison's disease or adrenal insufficiency. 8 AM cortisol along with ACTH in the morning, if cortisol is less than 5 microgram per deciliter and ACTH is 2 times above normal, then we have almost proved that it is Addison's disease. But many people will come with dubious values. They'll come with cortisol of 8 microgram per deciliter. Then what do we do? So we now do the synacthin stimulation test. So synacthin till 1.5 years was not even available in India. So we had to smuggle it from some different places only for testing purposes. It was very expensive. Now synacthin is available in India. We do a synacthin stimulation test. We give 250 mcg of synacthin, which is synthetic ACTH 1 to 24, and we give it subcutaneous in some institutes, IM in some institutes. The sample is collected at 0, 30 and 60 minutes. And if the patient is having a cortisol after synacthin of greater than 20 microgram per deciliter, we have ruled out adrenal insufficiency. But cortisol is less than 18 means it is adrenal insufficiency. Advantage of this test is it can be performed at any time of the day. So person comes in the evening also, you can do this test and see. But there are some conditions where you should not do the test. When patient is taking hydrocortisone, then that itself will show up in the assay. Or person has just had a pituitary insult, it will not show a positive result. When we were DM residents, we used to do something called as the short synecthin test. That is, we used to give only 1 microgram of synecthin to see if patient is having secondary adrenal insufficiency. So usually in pituitary disorders, 1 microgram synecthin also will not be able to stimulate the adrenals. Long acting ACTH, that is actin prolongatum test, is done in some of our institutes where we give 25 international units of actin prolongatum and this is given IM, and we take a cortisol sample at 1 hour and 2 hours. If cortisol is less than 18 at 1 hour or less than 19.5 in the second hour, we say it is adrenal insufficiency. Insulin tolerance test. Insulin tolerance test is it's supposed to be the gold standard for integrity of HP axis in secondary insufficiency. But all the people who have done insulin tolerance test, especially during the residency, they know how difficult test this is. You have to admit the patient, give IV insulin 0.1 to 0.5 units per kilogram. You have to wait for the person to develop hypoglycemia. Cortisol we measure at 0, 30, 45, 60, 90 and 120 minutes. Anytime the cortisol goes above 18, it's considered as normal. But even in presence of severe hypoglycemia, the cortisol is still less than 18, then it is positive for secondary adrenal insufficiency. Very, very difficult to do. You have to rule out ischemic heart disease, epilepsy, severe hypopituitarism, then only go ahead for doing this test. Certain other tests which we don't do in India very often is the metarepone test, which will help in, you have to give metarepone at midnight and check the ACTH and 11-DU cortisol on the next day. CRH stimulation test. Now CRH is not available in India, but if it was, it would have been a beautiful test. Because once you inject CRH, ACTH, which is already high in primary adrenal insufficiency, will become higher if you give CRH. In tertiary adrenal insufficiency, there the ACTH will be low, but if you give CRH, it will rise. And in secondary adrenal insufficiency, the ACTH will just not respond to CRH, and that will prove that it's a pituitary adrenal insufficiency. Now, person is very sick. Okay, now person is very sick. So, if a person is very sick, what will happen? The usual response of the body is only to increase the cortisol. Second thing is the cortisol binding globulin comes down in this particular patient, so total cortisol will be very less. So, testing a patient during illness is very difficult. You cannot do dynamic testing. Probably you just do a 8 AM cortisol and see what happens. That also we have to take it with a pinch of salt, because the total cortisol anyway is lower in patient with illness. If your lab is doing free cortisol, that is different, but I don't think any lab in India does it very precisely. Mineralocorticoids. So, in primary adrenal insufficiency, you will have low aldosterone and raised renin activity. So, renin activity will be increased, aldosterone will be low. That says that it is mineralocorticoid deficiency, whereas in secondary, the renin, angiotensin, aldosterone system is intact. Other tests that we would like to do on an OPD basis is the 21 alpha hydroxylase antibodies in some patients for diagnosing autoimmune adrenalitis. We do a CT scan of the adrenals and an MRI brain if you are suspecting secondary adrenal insufficiency. And for ruling out tuberculosis, of course, chest X-ray and tuberculin test is what we do. And very low chain fatty acids can be done for adrenoleukodystrophy. What will be seen on the CT? In the case of autoimmune adrenalitis, as I said, there will be initial enlargement, but after that it will be atrophic because of fibrosis. There will be small adrenal glands. Whereas in the presence of tuberculosis or infiltrative disease, the glands will be opposite. It will be enlarged and it will be calcified. How do we treat adrenal insufficiency in that case? Acute crisis, it's a life-threatening emergency. Don't delay the treatment while waiting for the proof. Put a wide bore needle, take a sample for glucose, take a sample for electrolytes, cortisol, ACTH, give IV fluids. You can give up to 2 liters of IV fluids in the first 4 hours only, and then depending on the fluid overload status, you correct it. Hydrocortisone 100 microgram, we have 100 milligram, we need to give stat, and then we need to give it every 6 hours on the day 1, 50 milligram every 6 hours on day 2, then shift them to higher doses of oral replacement and then go to lower doses. But always treat the underlying cause also, which is precipitating this. Long-term glucocorticoid therapy, we need to give with physiological, you have to mimic the physiological cortisol secretion in the body. How do we do that? The maximum cortisol is in the morning and it comes down in the evening and reaches a nadir in the night. So if you are treating with hydrocortisone also, we need to give a higher dose in the morning. Usually morning dose we give as soon as the patient wakes up. We give an afternoon dose at around 1 o'clock, 2 o'clock, and we give an evening dose at around 6 o'clock. Why don't we give hydrocortisone after 6 o'clock then? In the night, why don't we give hydrocortisone is because the normal physiology itself, cortisol is low in the night. And if you give hydrocortisone in the night, the patient will have severe insomnia and also the glucose metabolism will get altered. Which steroid to give? Hydrocortisone is the treatment of choice. Prednisolone is cheaper. Okay, so we have to give only 5 to 7.5 milligram of prednisolone. Dexamethasone can also be given, but the problem with prednisolone and dexamethasone is we cannot check for the HPA axis because HPA gets suppressed because of these medicines only. So we cannot stop and see whether the axis is actually recovered or no. So we do give hydrocortisone. So usual starting dose is around 20 milligram per day. We give 10 mg in the morning, 5 in the afternoon, 5 in the evening. And how do we know whether we are overdosing the patient? If the person is gaining weight, a person is having insomnia, peripheral edema, then we need to see that it's overdosing. Insufficient dosing means the person is not, his symptoms are not improving even after giving the hydrocortisone. That means nausea, poor appetite, weight loss persist means it may be insufficient dosing. We need to increase the dose. How to replace mineralocorticoids? We give fludrocortisone. So fludrocortisone usually we give 100 micrograms per day. So it can vary from 50 microgram to 300 microgram also in adults. It can go from 25 microgram to 200 microgram in children. Higher dose will be required per kg body weight for infants because of severe mineralocorticoid insufficiency. And how do we monitor these patients? See what is happening to their salt craving and lightheadedness. How is their blood pressure? What is happening to the edema status? What is the potassium? And if the patient can afford, you can also measure the renin to see if it's in the upper range of normal. If you're giving fludrocortisone and hypertension is occurring because of that, don't stop it, reduce the dose. In spite of that, if the patient is having hypertension, you treat with ACE/ARBs, but don't stop the fludrocortisone. That's very, very important. Some people talk about DHEA replacement in people who have persistently low libido, depressive symptoms in spite of giving glucocorticoid and mineralocorticoid replacement. But the evidence is very poor. You can try for 6 months, but usually you should discontinue if there is no beneficial effect reported. Special situations. Pregnancy is one special situation in which normally also the total cortisol rises in pregnancy because exact opposite thing happens. The cortisol binding globulin increases in pregnancy. So the same thing, when we are giving cortisol, hydrocortisone from outside, we need to increase the dose in pregnancy, especially in the 24th week onwards. We need to increase the dose. Very important thing in pregnancy is actually progesterone, which is there in pregnancy, it acts as a mineralocorticoid receptor antagonist. So if fludrocortisone dose might have to be increased in pregnancy, but if it is getting offset by just increasing the hydrocortisone dose, no problem. Otherwise, fludrocortisone also needs to be increased. Delivery, you cover it with IV steroid, 100 mg bolus, followed by 10 mg per hour till the patient is fit to eat properly, then taper to the pre-pregnancy doses quickly. I've come to my last 3 slides. So in special situations, like a person is very sick but can be managed at home, you can double the dose of hydrocortisone if the temperature is above 38, or you can triple the dose if the temperature is above 39. If the patient is unable to tolerate the food drugs because of gastroenteritis, you change to IV therapy. And lastly, what do you do if the patient is admitted in the hospital? Moderate illness, you can give 50 mg IV. Severe illness, you give 100 mg IV and then give it every 6th hourly till the patient recovers. For procedures, mild procedures, nothing is required. But for moderate stressful procedures such as barium enema, endoscopy, we need to give 100 mg IV stat. Of course, if the patient is undergoing general anesthesia, you give 100 mg IV bolus and then continue on infusion, or you can give a bolus every 6 to 8 hours. So with that, I'll conclude by saying that adrenal insufficiency, it is a condition. It can present insidiously or it can present as a life-threatening crisis. As Sir said, identification is the key. because if you identify and make an appropriate diagnosis, we can help in quick management and it may be life-saving as well. Appropriate replacement alone is not necessary. We should replace not only with corticosteroids, we must give mineralocorticoids and also counsel the patient about sick day management. That's very, very important. So with that, I think I'll stop. Thank you.
Very lucid presentation, Dr. Santosh.
Thank you.
You covered the entire topic, adrenal insufficiency, how to go about, how to treat it. Very well covered in the given span of 20 minutes.
Thank you.
Any questions from the audience?
They don't require fludrocortisone. So, any comment on that?
I cannot comment on that because I have not read about Algro syndrome since I think 15 years. Yeah, but I think we should use it on the basis of the patient's response.
Do we need to give bisphosphonates in all these people who are on long-term steroids?
So steroids are of two types. One is steroid treatment and the second is steroid supplement. So because we are only supplementing over here, bone health is rarely a problem. But it's a good practice to check for bone health at least once in 5 years in these patients. But most of them will not require any bone supporting treatment because we are only supplementing the steroids and not over treating them with suprapharmacological doses.